Welcome, everybody. Thank you so much for being here. My name is Karoom Lawrence. I'm the Chief Commercial Officer. Thomas is our CEO of Hemostemix. Today, we are going to focus on our cardiovascular story. We welcome everyone to our webinar. We see a lot of friends who come back week after week. We see a lot of new faces. We invite our clinicians, our patients, investors, regulators. We welcome everyone to our water cooler here around Hemostemix and Vessel. It's a time where we share our data and then get a lot of great feedback and Q&A, and we're grateful for your dialogue and the follow-ups. Thank you so much. We've gotten a lot of great emails and feedback afterwards that really helps refine our thinking strategically about how we're thinking about the science, about how we can really help patients and families suffering from vascular diseases. With that, I'm going to share screen, and today we want to focus on our cardiovascular story for ACP-01. And this is a continuation of how we're exploring a transformative approach to regenerative medicine. It's changing lives and redefining what's possible in cardiovascular care. There are millions of sufferers around the world, and we're focused on establishing the appropriate role for our stem cell therapy in the context of a lot of shifting landscape. We'd like to focus on heart failure today. We have some data we're gonna talk about. We showed it last time. We want to now clarify disease burden, talk about the new options with ACP-01, and then how to access care. Keeping in mind that Vessel ACP-01 is an investigational therapy under development and not approved by the FDA. And that is our first disclosure on this slide. We show this every time. Access to this investigational therapy is available globally, and in some U.S. states like Florida, there are other states that are coming, countries like Canada, and in our facilities in Bahamas, Dominican Republic, Switzerland, and others offer ACP-01 globally for several indications where we have phase 1 and phase 2 studies. And we talk about the need for patients, especially in Florida, they will be required to be provided an informed consent. So they are advised of the investigational nature of ACP-01. Patients may travel. You should always consult your physician. Treatments are generally out of pocket. I'm not a physician, but we'll be discussing scientific topics, and we'll be talking about medicine and the cost of care, our mechanisms of action, and our study data as we sort of go on this journey together. Our mission is something very meaningful. We think about it the very first second we wake up in the morning. It is really about helping healthcare professionals looking for a new option where they previously thought they may not have one. Our purpose is to help investors interested in revolutionary regenerative medicine opportunities. And then our leadership is really around helping patients and families searching for hope beyond conventional therapies. Last time we talked about our friend Howie Lindemann, who is now 75. He, at the age of 39, experienced a heart attack. And after several years of challenging heart disease issues, he was faced with a choice on open heart surgery. He did indeed choose ACP-01. He was able to look at the clinical data. This was back in the early 90s. It was exciting to hear from Howie on how he's doing and sort of the progression of his disease and what it means for an N of one. One individual who, is living, where he is very grateful to have not had a much worse outcome or to have his life shortened by heart failure or a heart attack. And he talked about changes in his left ventricular ejection fraction and energy. And just so everyone is clear, this was Howie's individual report. The clinical significance varies across all of our patients, and that ACP-01 is investigational, and its safety and effectiveness has not yet been established, but it has been tested in several phase 1 and 2 trials that we're going to talk about in a minute. So please check out Howie's story. We think that's meaningful and inspirational. The history of cardiology is interesting, and as previously noted, I joined really in the late 90s with Merck. That at the time, Merck was really the cardiovascular leader in the pharmaceutical business, focused on cholesterol reducers and ACE inhibitors and beta blockers. Those were really pivotal medications that reduced risk of heart attack and stroke and just became a mainstay for millions of patients around the world who are suffering from hypercholesterolemia and were at risk of heart attack and other things of that nature. Before that, there were lots of innovations around electrocardiograms and open heart surgery and implantable defibrillators, all super important. And now we're really in the stem cell era where we're focused on shifting from symptom management to really getting to the root causes. And of course, in our world, we're talking about ischemia, which is defined as a lack of blood flow to heart tissue that results in things like chest pain and things like damage to the heart. And so today we're going to be focusing in on the role of heart failure, which is really the heart's inability to pump blood effectively to meet the body's needs. And then also, what is the role of cardiomyopathy, which is a disease caused by weakening or stiffening of the heart muscle. Those three things go together. And so our central question and everything we do is what happens if we can improve blood flow to heart tissue? What is the result of that when you improve blood flow? We ask the questions, can we improve heart health or reduce risk of heart failure or other serious events? And we're going to be talking about that. The disease burden for heart failure is massive, and everyone sort of knows it, but when I look at the numbers again, 30 billion in the US, 284 billion globally. Heart failure is an enormous cost driver and financial burden in modern healthcare. I think it might be just one notch below oncology, but it has persisted as a top 5 disease area, I think, for my entire professional and adult life, and we often push on that. Why? What is behind that? And clearly we talk about things like Western diet and other things like that. I often think about longevity plans, and when you look at some of the really interesting ones from folks like Brian Johnson and Peter Diamandis, and I have developed a longevity plan, I often feel like it pays short shrift to the issues around heart health and heart failure. Yes, we talk about diet and exercise, nutrition, all of these things, but so many people, like we said last time, including my father, feeling great, showed up with a heart attack in January with a total blockage, which resulted in a heart attack. And so many people show up with something that could have been prevented, which would have improved their health and reduced their cost burden. And so we do double click on cardiomyopathy, as mentioned, which results in an impairing of pumping ability of the heart. And it's something that takes a lot of people by surprise. But when you get into the healthcare system impact, hospitalizations cost many thousands, defibrillators cost many thousands, chronic medications, and then the patient financial burden results in copays and specialist visits, advanced diagnostics, and all of these things. But essentially, heart failure from cardiomyopathy creates the cycle of costly interventions that goes on for years and years and years, and obviously results in a decline in quality of life and often sudden death, which is sort of horrific. We should be aware of the symptoms of heart failure. What does it feel like? How can you identify it? In our content, we talk about the symptoms of cardiomyopathy around severe shortness of breath, fatigue and weakness, persistent coughing and wheezing, swelling and edema. You'll know that we talk a lot about peripheral arterial disease. What happens if swelling and edema result in wounds that struggle to heal? And in this case, in heart failure, we need to start to learn more about measuring ejection fraction, like with an echocardiogram, and understanding how to measure reduced cardiac output and things of that nature, because that'll be important to understand the setup of our clinical studies that we've done in the past and how we're going to think about care for patients now, what those diagnostics are before, during, and after treatment, and then also into our new phase 1, phase 2, and phase 3 studies that are coming up. And so, the purpose of this call is to improve everybody's fluency around the disease burden, the symptomology, the diagnostics and tests. What does it feel like? What are the range of options that patients have? And if you believe you do not have options, there may be one more to think about, and it may be ACP-01, which is very interesting. And I'll talk about a little bit of why Vessel is interesting, right? Because now we're really in the space of very personalized to you, based on your blood, stimulating the development of cells that have specific functions drawn from your blood in a safe way. The functions support angiogenesis. They support new blood vessel formation. That then allows tissues that have been starved of oxygen and nutrition to receive that oxygen and nutrition. It allows us to reduce inflammation and to produce optimal healing environments in a targeted way. So that's one of the other interesting parts of the mechanism of action of ACP-01, is going to the area of need where there is damage. And then finally, the safety profile. Almost 500 patients have taken it. We'll talk about safety in a moment. 318 patients in our clinical studies, and what it means to use an autologous stem cell, which is your own blood, and that produces these functions. This is our mechanism of action slide from last time, where a VES cell will migrate to the areas of decreased blood flow, embed, release, and generate. I think it is interesting to talk about our MOA in terms of improving microcirculation through new blood vessel formation, which is what angiogenesis is. ACP-01 promotes cell migration. It helps release interleukin-8, which is chemokine CXCL8, and that fosters improved healing and regeneration as our MOA, and we believe maybe what's behind some of the safety and efficacy data that is presented here. We've very fortunate to have had a robust clinical program for the last 20 years. We've had 298 patients through 7 published studies. We now have 11 total papers. We've talked about that a lot. There has been one death that was an unrecognized silent myocardial infarction from one patient who was treated. It is not believed to be due to the stem cell therapy itself, but please, if you have any questions on that, we'd be very happy to pull that data up and discuss that in detail. And then today I'd like to focus on our heart failure data, which is Schubart here on the far right, open label study, 54 patients with severe cardiomyopathy treated by transcatheter implantation of ACP-01. We did cover this last time, but I think it's important to stay focused today on the heart failure story and the heart failure data, just so everybody's clear on how this works and the intention of ACP-01 and what it has produced in our clinical studies. Phase 1 and into phase 2, safety is really the focus of the endpoints. We do have efficacy endpoints, secondary endpoints, but primarily the summary of our safety data is that an autologous stem cell is a blood draw from the patient in office, no anesthesia needed, no complications associated with bone marrow harvest. The public perception of safety of autologous cells is higher. There are no ethical concerns as with fetal tissue that is part of some stem cell products, but the autologous cells are not tainted, no parasites, no risk of neoplasia. And then, as Fraser mentioned in our scientific review, which I would commend you to see, no risk of spongiform encephalopathy and Jacob-Creutzfeldt's disease, which is mad cows in humans. And then finally, no risk to medical providers, as it's a simple blood draw. And then in the case of chronic limb-threatening ischemia, there are injections back into the muscle of the calf. In the case of heart failure, a catheterization procedure into the heart itself. And in the case of vascular dementia, there will be direct injection into the cerebral spinal fluid. We'll talk more about that in the weeks to come. But as it relates to heart failure, we talked about this last time, and I want to just read through this data just so we're really clear on the outcomes and how the study was designed. This is an IRB-approved retrospective outcome study analyzing the effect of ACP-01 for intramyocardial and intracoronary implants on cardiac function in 52 consecutive patients with severe heart failure. Cardiac function was measured in terms of ejection fraction of the left ventricle. The normal ranges are around 55%. And at first follow-up, an average of 4 months after ACP-01 cell implantation for all types of heart failure, left ventricular ejection fraction was increased by 4.6% from 28.6 to 33.2, representing a statistically significant improvement, a p-value 0.0011. On final follow-up at average of 12 months, ejection fraction has improved by 7.69%, statistically significant. When analyzing ischemic heart failure alone, N of 41, ejection fraction increased from 29.9% before implantation to 34.5%, and then to 38.2% at 12 weeks of final follow-up for an overall improvement of 8.3%, statistically significant. The greatest improvement was in non-ischemic dilated cardiomyopathy patients, N of 8, who improved from 25.94 before treatment to 40.29% at final follow-up, p-value 0.003. So that, that bottom box catches our eye with that increase there for non-ischemic heart failure at 12 months. The service is important. And the service I think about is not just to patients, but also to the system-wide benefits of macro level healthcare being improved. The system benefits of reducing readmissions, reducing major heart events, fewer complications, lowering long-term care costs. We're very focused on that. We believe in the potential of ACP-01 to have major cost-saving benefits and benefits to patients in terms of improved quality of life, reduce out-of-pocket expenses, better outcomes. All these things are part of our mission and our value proposition. And so we do want to break the cost cycle. We talked earlier about, years and years of people suffering from heart failure and the symptoms leading up to it, when ischemia could potentially be identified and addressed. But, our investment in Vessel and the manufacturing of personalized medicine is, the very nature of it is significant. Our suggested manufacturing price, $50,000, and that's in the context of continuing standard care of costs. We're going to talk about the cost of getting ACP-01, all the ways we're trying to help with access, especially low monthly payments, a 501c3, we're going to cover that in a second, but we're really trying to show healthcare systems and patients and physicians where the break-even point. So it's clear, so people can make a decision to say, I'm facing several $100,000 of healthcare costs based on conventional standard of care, or I have an option that may be, frankly, more affordable and help reduce overall utilization with sustained long-term value. So that is something we are investigating and exploring in our trials now and going forward. That's why we are excited to hear from Howie, who has had many years of life sustained for him. We have a second patient who's going to be coming on the webinar, who's also lived, I believe, for another 2 decades after his first Vessel treatment, which was, I believe, he was patient number 57. But the point is, we are trying to make access to this unique kind of care easy and affordable and understandable of how it fits in to sort of the complexity of understanding and managing cardiovascular disease. If indeed you are a physician or a patient and you would like to have a discussion on the clinical care workflow of how to get ACP-01, the most important thing and the first step is to establish qualification. So you would call your clinician who has been trained on ACP-01 or one of the Hemostemix care centers where we would request your diagnostics, the echocardiograms, the cardiac MRIs, or other tests. If you do not have one, we can help arrange new ones. Sometimes and often those diagnostics will help us understand if indeed you are qualified or not for Vessel therapy. If you are qualified and one of our trained clinicians agrees, then we would help you, we would notify you that you indeed are qualified. We would transfer you to travel and payment and scheduling assistance, one of our trained navigators. They'll help you understand the affordability options of getting care, especially low monthly payments, and then travel, how and where to get the blood draw, which is very convenient, can really be done anywhere. That goes to our good manufacturing practices facility in Puerto Rico, where our clean room is, where our cells are cultured, and then returned 7 days later to be re-injected into the patient. And that is it. We've been talking about this as a 2-step sort of done for you process to make it as easy as possible for healthcare providers to understand how to qualify patients, how to get care. And then sort of finally is the hard work needed to help patients afford therapy. And number one is our treatment convertible debentures, which is an investment vehicle that allows you to pay for the cost of care. It allows you to earn 6% on that money. Those funds are used to reserve your spot in line. Like as you can understand, our manufacturing of the stem cells is in a sequence where we schedule your therapy, and then you would then go and receive care. Secondly, low monthly payments, working with a number of banks. We have our first one approved. We'll be putting that on our materials where you can receive payments. I believe they're in the realm of $800 a month. We think that number to us is sort of rationalized on what you would be paying out of pocket for other care, and also in the context of the onset and potentially the durability of treatment itself. So you understand how therapy fits in, the value to you out of your pocketbook, and then finally the 501c3, our foundation. We urge all of our well-to-do patients that can afford one for themselves to please contribute a therapy for someone who cannot afford it. We are very eager to expand access to our foundation, and there will be other access innovations coming on. So that is what we have for today, and we cover this each week. Finally, for physicians and patients, for clinical trial enrollment, or wait lists, or reserving care, or for any questions around compassionate use, or location to get care, or payment options, please reach out to me at clawrence@hemostemix.com. For medical affairs or anything around clinical studies and trials, please reach Dr. Fraser Henderson, our Chief Medical Officer. And finally, our CEO, Thomas Smink, for any question you might have for partnering, investing, expanding access. Thomas, who's been working with Hemostemix, I believe, since 2006. Thomas, you'll correct me, knows the most about this, the momentum we're building in terms of regenerative medicine in the cardiovascular space. So a tremendous resource, Thomas. So I will stop there. And thank you, everyone. So we'll go into Q&A. Thomas, let me give you, if you'll, I should let you have the mic for a minute to correct anything I might have misstated or to add. So, and then we'll jump into Q&A.
Well, just in terms of how he was treated in 2008, and his results have persisted for some 17 years. In Niam's case, we will get the full story from him. Just as interesting a case, quite frankly. And Niam's got, I think you're right, it's closer to 20 years of benefit. Again, Roger Burgesson, my co-founder, 13 and a half years of family love and life from one vessel treatment. So while those are very significant improvements or runs and with quality of life, you could see from Howie that firsthand there's a 74-year-old man who's running around like a younger version of himself, and was totally supportive of getting on any call with any patient to talk about his journey and what people could expect. So I think that a great overview, Kroom, of exactly how we're going to market in Florida. One thing I would add is that Florida does represent a significant opportunity for the company to capture data, patient data going forward, real world experience data. And we have designed our patient follow-ups to be consistent with the phase 1 style of follow-up, so that patients can expect to be followed at 3 months post-treatment, 6 months post-treatment, 12 months post-treatment. And we will measure the effects of Vascel in terms of the improvement of their left ventricle ejection fraction and the improvement of their exercise capacity, a 6-minute walk test, and the improvement of their quality of life, how we measure quality of life in terms of the SF-36 health survey. And these will accumulate and be statistically significant real world experience data. And to put that into perspective, from a regulatory point of view, the FDA has recently approved phase 1 only patient data companies. One that comes to mind was for the treatment of type 1 diabetes, where 30 patients in a phase 1 study were followed for up to 5 years, and the FDA approved that treatment based on that phase 1 only data. So whereas now we have, as you rightly pointed out, 225 patients that have been followed, and we've demonstrated complete safety, statistically significant efficacy in the improvement of the volume of blood generated by the heart, improvement in the exercise capacity, improvement in quality of life. That is, we will continue to log those details patient by patient in Florida. And that will be married up with the data that we generate from our additional clinical trials, including what we've discussed previously as a basket phase 1, to prove that just as it's worked at the end stage of the disease process, we want to prove that it works just as well at the beginning stage of the disease process. So that, to your point on the healthcare costs, rather than going down the standard of care model, people who are younger or middle-aged who have been diagnosed with this and are at a class 1 or class 2 form of their disease as compared to a class 4 where we've demonstrated results, they have the option of going down a vessel route that promises to improve their heart function, exercise capacity, quality of life. So great job, Krum, and not sure if we've got any questions.
I do see a question. Will there be a near-term meeting with the FDA, and are there any future plans or hope for a possible uplift to the NASDAQ without a reverse stock split?
Great question. So in the first instance, with respect to the FDA, yes, we are planning a meeting with the FDA and that should be before the end of the year. We'll have further announcements on that. And yes, we do plan to uplist to NASDAQ without a reverse split. And the way that is likely to happen is through the sales of treatments in Florida, so that it's a revenue-based increase in valuation that we will be relying on. And there are other business developments that we've been working on that will have a similar net positive effect on valuation going forward. Hemostemix, as compared to its US peers, is really valued around 1/10 of its US peers. And so it will revert to the mean in terms of its valuation. And we are working very diligently to get that done.
Fantastic. Okay, here's another question. Thank you so much. I'm interested in purchasing a convertible debenture for myself. Am I right to believe I can convert the debenture to shares, and at what price? There's nothing wrong with me now, but I'm 67, and who knows what the future will bring. Can I delay my treatment?
Sure. So yes, we can sell you a therapy convertible debenture. You'll earn 6% interest on your investment and that will be paid in shares of the company. Is convertible into a treatment on the one hand and shares on the other hand. And thank you for your interest. Please reach out to me directly. I will get you a term sheet and fill in the details. But this is an approved investment, approved by the Toronto Stock Exchange. And this is a very innovative way for you, on the one hand, to have the option to take a vessel treatment. On the other hand, buy the investment and get paid 6% interest on your investment while doing so.
Fantastic. Thank you for that. I remember from last week or 2 weeks ago, there was a question on the status of some of our partnerships like HubSpot and other tools. So yes, indeed, we have signed contracts with HubSpot. They are our CRM provider. They help us manage our patient omni-channel ecosystem, and they're a fantastic partner. Medrio is another partner that we have signed with and used previously. They help us with our clinical trial data. So they're a world-class partner that will capture all the patient records in a HIPAA-compliant database, and all that data captures there, and that helps us then obviously with our reporting and development of our papers. And there's several others, but that was a good question from a few weeks back.
Yes, and we put out that announcement this morning on vesel.health. And Krum, you can do this much better than I can in terms of defining the geofence that is required in the US and why, but how we are essentially looking at and do geofence our messaging to Florida and Floridians for now, to Canadians and others globally, but how we have to meet both the federal and state requirements on messaging. So I think it would be helpful if you touched on that.
Yeah, it's a great question and something we think about and work hard on every day. The most important and clearly defined node, I would say, is Florida, right? We have a very clear law as of July the 1st, SB 1768, where physicians in their swim lane perform consent and get that consent from a patient, and they disclose that this is an investigational study that is not approved by the FDA. But Florida and the stem cell community believes strongly in the safety of stem cell therapy, that especially that is autologous. So we're now going to market under the auspices to support pain and wound care. So those two indications fit our therapy and our data. And so we geofence that with our digital communications, with our owned websites, through our clinical partners in Florida, and the education and messaging and helping people find where to go is 100% geofenced in the state of Florida. So that is an essential effort within the United States. Outside of Florida, and the United States, notwithstanding the other states that are coming online soon, but in the broader FDA and U.S. Regulatory environment, there is 100% compliance with every regulation per FDA that is required of us, and we are focused on that. And that is primarily around clinical trial recruitment in the U.S., knowing that Kennedy and the leadership at FDA and otherwise do have a stated goal and a strategic desire to reshore stem cell therapy. And so we're discussing that, listening for those signals, looking for those changes in regulatory policy to bring the stem cell community to the United States. And please note, we are already doing that through our compliant facility in Puerto Rico. So we're well ahead of the curve and safe manufacturing in a GMP facility in the United States, in Puerto Rico, with a phenomenal team down there. Outside of that there is a commercial business around stem cells, and that happens to be in the Bahamas and Dominican Republic and Switzerland and many other countries, which I think there are 4,000. I think you mentioned a stat the other day, but there are thousands of stem cell facilities around the world. And part of that 5,000, part of that is enabling access to care to our global community, all in the context of those regulatory environments and in the context of the Canadian regulatory environment. I think we are doing a good job of clarifying those rules and regulations and living within those rules. And we strive for that every single day.
Yeah.
Our work is never done.
Yeah, it's never done, and it's a changing landscape. As we're witnessing, we're in conversations with governments, with practitioners in states and in districts, for example, like DC, that are looking at Florida's law and are contemplating moving forward and becoming a state similar to Florida in terms of a jurisdiction where at least autologous stem cells can be used to treat various forms of no option heart disease and other forms of other diseases. So it's a challenging landscape on the one hand, it's an exciting landscape on the other hand, and we are literally, I think, in a new era where regulators, politicians have come alive and have are getting a better understanding of really the logic of using your own stem cells to regenerate your heart function, for example.
Fantastic. Got another question coming in. Thank you. Is Hemostemix conducting treatments now?
So we are scheduled to start first treatments in December. We again have treated 498 patients in the past. We are reestablishing production in Puerto Rico, which is an FDA jurisdiction, and we're on schedule to have first treatments in December.
Okay. All right. Thank you, Thomas. Okay. Thank you to everyone for those questions. All of our webinars are uploaded to our YouTube channel. We do a lot on LinkedIn. A lot of our invites to our webinars and other events are often through the social channels on X, etc. Frankly, a good resource are the LLMs. My understanding is they've read all of our material and frankly do a pretty good job. I think the LLMs are about 90% accurate. 5 to 10% may be a hallucination and often in the numbers, but we encourage everyone to look for us there. It reminds me of another question about our proprietary LLM on Vesel.health. Her name is Dana. That is a service provided by HubSpot that has read all of our materials on our site. So if you have any specific questions, I would even say it's a little bit of a dream come true. Chatbots have been around since the early 2010s, and that were just very simple. Now we really do have a more intelligent AI service for 24/7. If anybody has any questions, anytime. All of our publications and data predominantly have been read and ingested, and so you have access to that customer service person around the clock. And we would encourage you to have a chat with Dana and have your questions answered. If there's anything else, please reach out to us directly. I do see another. Oh, this is a great one. So Thomas, thank you for the kind words, and also thank you for this question. Can you tell us anything about NCP? So that's a great topic. NCP.
Yeah, so NCP is the sister cell, if you will, to ACP, and it is created essentially from the same source product, the patient's blood. The synergetic cell population is educated to become neuronal cell precursors rather than angiogenic cell precursors. And we have a program focused on completing an animal study of NCP at Clemson. And then we want to move it through its natural progression. You can see that in our press releases, we've talked about NCP and ACP in combination. In fact, just published this summer in Cells, the science behind the use of ACP and NCP as a substrate, really, to improve angiogenesis at the site of implant of brain-computer interfaces, and to improve the signal uptake of those BCI. And so NCP is a very exciting cell line. We've got previous data that shows, similar to ACP, really two models. One is a model that was where there was a detachment of a retina and then the injection of NCP into the eye. And we demonstrated that NCP homed to the site of the detached retina and bedded there. The second model was a stroke model of nude rats, where there was a stroke induced in the brain of the nude rat, and cells were color-coded in 3 different colors and injected 3 different ways. 1 into the skin, 1 into the muscle, and the 3rd into the vein. 10 days post-injection, those animals were sacrificed and the color-coded cells were counted across the anatomy of the rat. And more than 90% of the cells, regardless of the method of injection in each case, ended up at the site of stroke, demonstrating again the homing mechanism of NCP, and that in parallel is how the homing mechanism of ACP works in the case of heart disease, homing to the site of ischemia. So that's where we're at on NCP currently, and very interested in moving that forward in parallel to ACP. One of the things that, one of the benefits of having done all the work in ACP first is that we can prove to the regulator that NCP is essentially a sister cell to ACP. So we should be able to move it into human trials very rapidly because we have the...
Awesome. Thank you to all your questions. Okay, just to make it easier, regarding the question of our chatbot, Vesel.health, Vescell.health is where you'll see our chatbot there. If you have trouble finding it, just let me know. Thank you to everyone on the call. We're grateful to our community. Please come back This is important as we all move forward, and we look forward to seeing you again every Thursday at 12 o'clock. So please come back and join us.
Excellent.
Great. Have a great day, everybody. Thank you
Thanks,
so much.
Chris.
Okay.